Welcome back to the deep dive. Today, we're tackling a really huge transformation in the U.S. health system: ambulatory care.
It's a fascinating area because, well, even the term ambulatory care means so much more now.
Right.
At its core, it's just healthcare where you don't need to stay overnight in a hospital.
Hmm.
But, go back a few decades, and that was pretty much just your regular doctor's visit.
Mm-hmm.
Today, it covers complex surgeries, high-tech diagnostics, those urgent care places you see everywhere. It's a massive expansion.
Absolutely. It's gone from being sort of a sideline to a really critical part of healthcare. So our mission in this deep dive is to unpack how that happened. What were the big drivers, the money, the tech, the new ways of organizing care that basically pulled services out of the super expensive hospitals?
Yeah, and push them into the community settings we see now.
Okay, so let's dig in. If we're looking at this huge shift, this migration of complex stuff, where did it start? What kicked it off?
Honestly. It was largely driven by Medicare back in the late 1980s. The real game changer was the diagnosis-related group system, the DRG system.
Ah, yes. That was the big switch to prospective payment, right? Instead of hospitals billing after the fact for whatever they spent.
Exactly. Before DRGs, the incentive was, frankly, to keep patients in beds longer. More days meant more revenue.
Simple as that.
DRGs set a fixed price for a diagnosis. So suddenly the hospital had a very strong reason to be efficient, to shorten those inpatient stays, and crucially, the financial risk. It shifted from Medicare to the hospital.
Okay, so those expensive inpatient beds, if they weren't full, they weren't just sitting there, they were actually costing the hospital money.
Precisely. They had to find ways to use that expensive real estate more profitably. Often that meant converting parts of the hospital into outpatient service areas.
And wasn't managed care also a big factor around then?
Oh, absolutely. The rapid growth of MCOs, managed care organizations, added even more pressure. They were all about finding the least expensive, effective way to deliver care, which almost always meant pushing things towards ambulatory settings.
So the outcome wasn't just people going home from the hospital sooner. It was this massive build out of capacity. We saw huge growth in outpatient clinics inside hospitals, but also all those freestanding centers starting to pop up.
And that financial earthquake, it didn't just shake up hospitals. It completely changed the way physicians practice medicine, too. I mean, we should remember, private doctors' offices are still the main place people get ambulatory care. Nearly 900 million visits back in 2016.
But the life of those doctors looks totally different now. If you go way back, before maybe 1960, most doctors were true solo practitioners.
Yeah, can you imagine? Responsible for every single patient, 247. The demands must have been incredible.
Just enormous. Time, energy, personal life.
They had to be generalists, really. But after the 60s, you saw specialization take off, and doctors started wanting, a bit more control over their lives. That pushed them towards group practices.
And something often missed here is just the sheer paperwork, the administrative side.
Oh, definitely. When Medicare came in, 1966, billing suddenly got incredibly complex. All these government rules, fee schedules.
Not so simple anymore.
Not at all. For a solo doctor, handling all that, plus maybe affording new diagnostic gear, it got really tough. Joining a group meant you could share those overhead costs, share the administrative burden. It just made economic sense.
Which leads us right to the next big step in that evolution: doctors actually becoming employees. You mentioned that data point, 2016, 2/3 in groups. But by 2018,
Right. By 2018, more physicians were employed, 47%, that actually owned their practice, which was down to 46%.
that's a huge
Shift away from the traditional independent doctor model in just a couple of years.
Why did that happen so fast?
Well, several things. Reimbursement rates from insurers weren't really keeping up with costs. Then there's the huge expense and complexity of electronic health records, IT systems.
Yeah.
Add in rising malpractice insurance costs, and, frankly, a desire among many doctors for a better work-life balance. Being an employee offers more predictability.
And for the hospitals or health systems doing the employing.
It's strategic. Employing doctors helps secure market share, it directs referrals to their facilities, and it positions them better for things like value-based care models.
Okay, so this move towards employment, it's partly a response to a system that wasn't working perfectly, especially that old fee-for-service payment model.
That's a key point. The traditional way, paying for each individual service, each test, it encouraged volume, not necessarily coordination or the best outcomes. It led to fragmented, sometimes inefficient care.
Because nobody was paid for the time spent coordinating everything for the patient.
Exactly. Which brings us to the big system reforms, like the Affordable Care Act, ACA, and Medicare. They tried to tackle that fundamental problem.
Can you quickly remind us what Make-Harari is? It pops up a lot in these discussions.
Sure. Make-Harari, the Medicare Access and CHIP Reauthorization Act, is really the law that's pushing Medicare payments away from pure volume towards value.
Right.
It sets up systems where doctors and hospitals have to show good quality outcomes to get paid properly. It basically laid the groundwork for these newer models of care we're seeing.
Right. These models that are supposed to be more effective, more efficient,
Yeah.
better for the patient experience overall.
And the two big ones are the Patient-Centered Medical Home, or PCMH, and the Accountable Care Organization, ACO.
Let's start with the PCMH. It's not just a place, right?
No, not at all.
Oh.
Think of it like having a lead coordinator, a quarterback for all your healthcare needs. It's team-based care led by your personal physician, focused on continuous coordinated care over time.
And it has specific functions it has to perform.
Yes, there are core principles. It needs to be patient-centered, involving you and your family. Comprehensive, looking at both physical and mental health. Coordinated, working smoothly with specialists, hospitals, pharmacies, the whole medical neighborhood.
Okay.
It also has to be accessible, meaning better access, maybe 24/7 contact options, shorter waits, and finally, committed to quality and safety, using data to constantly improve.
And the key is it actually pays doctors for that coordination work, not just the face-to-face time.
That's the crucial difference. And ideally, the PCMH model serves as the primary care foundation for the second big model, the ACO, the Accountable Care Organization.
Okay, what's an ACO?
An ACO is basically a network. It's doctors, hospitals, other providers who agree to take shared responsibility, both financial and medical, for the care of a specific group of patients. The goal is to coordinate care really well, to avoid unnecessary tests, procedures, hospital stays, essentially to provide better care more efficiently.
So if they succeed in keeping their patient population healthy and costs down while meeting quality targets, they get to share in the savings.
Exactly. It aligns the financial incentives with good, efficient care. For Medicare ACOs, they have to manage at least 5,000 beneficiaries for 3 years, and their payments are increasingly tied to performance, sometimes through bundled payments for episodes of care.
And these are becoming pretty common.
Oh yeah. By 2020, there were over 500 Medicare ACOs looking after more than 11 million people. It's a major direction for the system.
So we have these big integrated system changes happening. But alongside that, there is also this explosion of, well, convenience-focused options, right? Driven by us, the consumers.
Absolutely. Starting maybe in the 80s and 90s, people wanted easier access closer to home. That demand really fueled the growth of freestanding centers. Take ambulatory surgery centers, ASCs.
Right, outpatient surgery places.
They started back in the 70s, mostly owned by physicians themselves. Doctors saw a chance to do surgeries outside the complex, sometimes slow hospital environment. Advances in anesthesia and surgical tech made it safer to do more procedures on an outpatient basis.
And they really took off. You mentioned a stat by 2012.
Yeah, by 2012, ASCs were doing something like 65% of the surgeries that previously would have only happened in a hospital setting. A huge shift.
Then you've got urgent care centers, UCCs. They seem to be everywhere now.
They really are. Over 9,000 of them by 2019. They fill that gap for immediate non-emergency issues. You know, the flu, a sprain, minor cuts.
And what's really interesting is that most people using them already have a primary doctor.
That's right, about 2/3 do. It just shows that traditional primary care hours often don't match up with when people actually need care urgently. UCCs offer that walk-in convenience.
And they're way cheaper than going to the ER for something minor.
Significantly cheaper. And taking convenience even further, you have the retail clinics, RCs, the clinics inside pharmacies or big stores like Walmart.
Staffed often by nurse practitioners or physician assistants?
Correct. They're really an entrepreneurial response to demand for super quick, affordable care for very common, easy-to-diagnose things, strep throat, vaccinations, that sort of stuff. And their costs are generally much lower than a doctor's office, urgent care, or the ER. Very appealing if you have a high-deductible insurance plan.
This whole drive for access and convenience seems to be hitting its peak now with telehealth.
You can definitely say that. Telehealth is sort of the ultimate convenience. Live video visits, sending images or data for review later, remote monitoring devices, health apps on your phone. It covers a lot.
Insurers were a bit slow to pay for it initially, weren't they?
They were hesitant, yeah. Concerns about billing, quality, but the COVID-19 pandemic just blew the doors open. Necessity forced rapid adoption and reimbursement changes. Now patients expect it, and services are expanding like crazy.
Okay, so we have all this private sector growth, convenience care, but we also need to talk about the safety net, the federally qualified health centers, FQHCs.
Yes. Extremely important. FQHCs started back in the 1960s, part of the war on poverty. Their whole mission is to serve medically underserved areas and populations.
And they have to offer care regardless of someone's ability to pay, right?
Right.
Sliding scale fees.
Exactly. No one can be denied care because they can't afford it.
Right.
But what's truly remarkable about FQHCs, despite serving populations that often face the biggest health challenges and barriers to care, their outcomes are often excellent.
The data's impressive. Like, nearly 80% are recognized as patient-centered medical homes, and they actually do better than the national average on things like controlling high blood pressure and diabetes for their patients.
It's really a testament to the power of integrated, mission-driven primary care. They show that providing high-quality coordinated care works, even for the most vulnerable.
It's a powerful point for population health,
Mm.
absolutely. So, pulling this all together, what we're calling ambulatory care today is just vastly different from what it was. It's this complex mix: hospitals running outpatient centers, huge doctor groups, standalone surgery centers, clinics and pharmacies, digital visits. It's fragmented, yet trying to be more connected.
That's a good way to put it. The whole system is pushing towards trying to control costs while making things easier for patients to access.
So if we look ahead,
Yeah.
what's the big tension? What's the next challenge here?
I think the core tension is coordination versus convenience. On one hand, you have models like ACOs and PCMHs that absolutely depend on tight coordination, on having that single quarterback managing all aspects of your care.
Right, the medical neighborhood idea.
Exactly. But at the same time, consumers are voting with their feet and their clicks for maximum convenience. That's driving the huge growth in urgent care, retail clinics, and especially telehealth. These are often more transactional, focused on immediate needs rather than long-term relationships.
So the big question is, how does the system square that circle? You've got this powerful demand for easy, maybe disconnected access points, but the payment models are pushing towards highly integrated, coordinated care to manage costs and quality for whole populations.
Precisely. How do you integrate that convenient on-demand care into the longitudinal, comprehensive models that ACOs and PCMHs are trying to build, especially as care becomes more virtual? That's the tightrope walk for the future of ambulatory care. How do we get the best of both worlds?